Welcome, everyone, and thank you for joining us today. This webinar is part of the Understanding and Addressing the Childhood Chronic Disease Crisis series by the Connected Communities Health Initiative. Today, for session 2, we will focus on prevention and action in primary care practice, and we look forward to exploring key strategies to better understand and address this important issue in childhood health. Let's begin. Next slide, please. Let's start with a few housekeeping items. All participants will be muted on entry to minimize any background noise. We encourage you to use the Q&A or chat box if you have any questions during the session. This webinar is being recorded and all materials will be emailed to you afterwards. We really appreciate your feedback and we ask that you please complete the brief evaluation at the end of this session. Next slide, please. Let's learn a little bit more about the Connected Communities Health Initiative, also known as CCHI. Our national training and technical assistance partners work with health centers to improve the health and well-being of their patients and communities. We provide practical tools, resources, and learning opportunities that empower providers to tackle the root causes of health challenges and deliver lasting positive change. Next slide, please. The purpose of this series is, number one, to increase awareness of childhood chronic disease trends impacting young health center patients and their families, identify the key drivers highlighted in reports and studies, and last, connect report findings to community health management, quality improvement, and integrated care initiatives. Next slide. After this session, we will have 5 more sessions in this series. Session 3 will take place on February of 2026. You can access additional details in the chat. Information about session 4 through 7 will be provided at a later date, so we encourage you to keep tuned and inform about these next sessions coming up. Next slide. Today, we're delighted to welcome Dr. Kevin Lombardi and Dr. Jose Leon from the National Center for Health and Public Housing. They will be presenting insightful case studies to help us explore this topic. Additionally, myself, Esli Reyes, Health Center TTA, and Partnerships Manager at the National Center for Farmworker Health will be supporting this topic, providing a community health worker perspective. We're happy to be here and we hope you all learn a lot from this topic as well. Next slide. This webinar has been planned and being brought to you by the Farmworker Justice, the National Center for Farmworker Health, the Association of Asian Pacific Community Health Organizations, and the National Center for Health in Public Housing. More information will be sent in the chat as well, where you can learn more about each of our organizations and the services we have available for you. Next slide, please. All right, so now let's dive into our learning objectives for today's session. We hope today we will learn about screening tools for dietary intake and chemical exposure. We will also do a demonstration of integration into common electronic health record platforms. And we would also discuss workflows and documentation strategies for health centers. Next slide, please. Well, and to begin, and also to set the stage, let's review some key facts regarding the main themes of this session, which are diet, chemical exposure, and the health of children and adolescents. So children and adolescents are at a key stage of development. Their bodies and brains are still growing, so diet and chemical exposures can have a stronger effects during this period. Diet plays a dual role. It provides essential nutrients, as many of us may know, but it can also be a source of chemical exposure through food, water, and even the air they breathe. There are potential health impacts. Several studies link these exposures to change in growth, metabolism, and learning or behavior. And why is this important? Why are we here today? Because it's important to understand how diet and chemical exposure interact, and it helps support healthier choices and long-term well-being for children and youth. And building on this foundation, Dr. Lombardi and Dr. Jose will now guide us through a series of case studies that will offer valuable perspectives and practical approaches to the topic. And with all that, I'm going to turn it over to you, Dr. Lombardi.
Hi, everyone. Kevin Lombardi, MD, MPH, medical doctor, epidemiologist. Today I'll be talking about childhood obesity broadly, giving you some resources, and we will go together into a case study so we can pick at some of the issues and talk about how we discuss things with patients and how we can set them up for success. This is a childhood obesity. Obesity is a truly frightening issue. We have today an issue that we didn't have a generation ago, 2 generations ago. There are children that spend their whole lives, the whole childhood lives with obesity, and that fact alone sets them up for a variety of sequelae later on in life that are negative and in terms of their health and well-being and their enjoyment. There are many children that, because of their diagnosis of obesity, are never able to run, never able to use their bodies in a way that is healthy and active. And as a result, as adults, their likelihood of developing type 2 diabetes, cardiovascular disease, both, and many other conditions is greatly, greatly enhanced. As clinicians, when we intervene at this age, well, with any issue, when you intervene at a younger age, the potential benefit down the road is strengthened and exacerbated. But in particular with this issue, if we're able to intervene with healthy lifestyles, to intervene with dietary counseling, public health guidance, we're able to not just help the child now, but help their future adult selves as well. And as in addition, help their families. These are rarely isolated issues, and often when there is a child that is dealing with issues with diet, with obesity, is because of diet and lack of exercise, most often. And often family members and their direct caretakers are having that same issue as well. We can use these opportunities to intervene to educate the entire family unit and to help them to live their best lives and to be their best and healthiest selves. Also, in the context of value-based care, a patient with obesity is much more expensive to take care of. It takes more health system resources, emergency resources, health center resources, and systems from the benefit of it is to the benefit of both the patient and the system to take care of this issue at a young age and make sure people live their healthiest and fullest lives. So first, some resources, a great guide for the pediatric wellness visit, and in particular, the interdisciplinary team conversations that should form an ecosystem around it. On the bottom left here, the UC Pediatric Wellness Visit Guide, and just a little bit about that before we go into the case study. Pediatric wellness visits are core opportunities to intervene, particularly in this issue, and core opportunities to both educate the patient and the clinic in the clinic, and to connect them to resources to continue that education. With any health issue, it's very difficult to see an immediate change in behavior, which is conversation with a physician or an advanced provider in the clinic. When we connect folks to resources, including CHWs, behavioral health professionals, and so forth, depending on the patient's needs, we increase the likelihood of that behavior change substantially. And when we're talking about pediatric wellness visits, also other things that affect adults as well, these professionals, CHWs, behavioral health professionals, they to a certain extent pay for themselves because they lower the cost of care overall so much through their interventions. So if I see we have some CHWs here, you guys are so critical to the health system. Thank you for what you do. Let's talk a little bit more about pediatric wellness visits. Next slide, please. The pediatric wellness visit is a fundamental tool in reducing rates of obesity. It is an opportunity to intervene, an opportunity to educate, and an opportunity to act. It also serves as an interdisciplinary forum for MDs, nurses, dietitians, and CHWs to contribute to patient care, coordinate that care, and implement that care. Value-based care models provide health centers with financial benefits for completing screening, lowering emergency room visits, and preventing diagnoses. So it's great when incentives align for anything in life. And with this particular issue, when we're doing our making sure we are getting our pediatric visits done, we are lowering cost of care and we are increasing we are improving the patient's health as well. It is a win-win, truly. Next slide, please. So we're going to start by talking about Jason. I'm going to read the clinical case, and I'm going to throw you all some questions, and I'm going to ask you to put your own professional hat on as I read things, reflect on how you would intervene with this individual. We have Jason. He's a 15-year-old male who presented to the primary care clinic for follow-up regarding obesity and nutritional concerns. He lives with his mother and niece and has expressed interest in achieving a healthier weight, but reports difficulty maintaining lifestyle changes and limited support at home. Common story. His height is 5'6" at 167.6 centimeters. Weight is 200 pounds. Body mass index is 32.3, and that is the 98th percentile for age and sex for his obesity classification. Let's take all that information in. Next slide, please. So I have some questions to pose to the group, and I'll read them and we'll go back to the slide and take a look at the data. What are your primary concerns regarding Jason's health at this point in the visit? And how can we use this pediatric wellness visit to provide the most benefit to Jason? I'll ask the team to go back another slide to the first slide of the case again. Just back one, please. So I'll throw it to the group. In the chat, please, what do you think? What are our opportunities here? Let me take a look, see what the chat says. Oh yeah, so what do his labs tell us about the clinical state? We are going to want to see some additional tests, 100%. Healthy foods for children, school breakfast and lunch, part of the advocacy, and teaching program and how to prepare foods and picking food choices after picking good foods. 100%. These are things that should be integrated into direct educational conversations with not just the patient, but the family as well. Is food available? Yes. Well, the interesting thing about obesity is that it can often mask food insecurity, which seems counterintuitive. But when families are financially stressed, they often are more likely to buy high calorie and low nutrient foods, which of course are available everywhere in our toxic food environment. Our food environment is in general very toxic. High in carbohydrate, high in sugars, sugar hidden in everything. And how can we expect families to navigate this, especially if they have limited health understanding and literacy? Support at home. And these are immediately the things we think of. Just to look deeply in here, he lives with his mother and niece, and he expressed interest in achieving a healthier weight. So we have sort of a non-conventional household here. It looks like there's one caregiver there. There's a niece, which means like there's a younger family member that's living there as well, and difficulty maintaining lifestyle changes. I mean, this makes a lot of sense given just the limited things we know about this family structure. And of course, the BMI is very solidly in the danger zone, and it is time to intervene. So let's see what else we have. 2 slides ahead, please. In general, BMI does not change with ethnicity. But also there are severe limits to using just BMI. There are differences in individuals in bone densities, but typically those differences between individuals greatly exceed differences between racial groups. Concepts of racial groups are subjective, not scientifically based. But if we use just the BMI, to diagnose obesity. We miss a lot of the picture, and it eliminates our ability to really take care of, meet the patient's direct needs, which is why we like to look at BMI with things like one, a physical exam, the how the patient's body looks. If this is a bodybuilder, then their BMI is going to be high. Is of course this is more of an issue for adults, and of course, what do the labs tell us? The labs tell us about what's actually going on in the body. And right here it tells us this BMI actually does reflect a very serious issue with nutrition and quality and quantity. So when total cholesterol is elevated, this patient is eating high cholesterol foods and low nutritional density foods. LDL cholesterol is elevated. HDL is low. Of course, the LDL often called the bad cholesterol and the HDL the good cholesterol. In general, when you are seeing a patient that has an LDL that's high and an HDL that is low, that is predictive cardiovascular disease. And if he's having this as a child, imagine as an adult, and imagine that atherosclerosis building later on. I think it was first in the Vietnam War when they were getting people 18, 19 that were killed during the war and doing autopsies that they were finding that these Americans actually had, even at that age, very late stage or developed cardiovascular disease, atherosclerosis, even at that age. And it's because of the quality of the food we eat in this country. It's very high in fat, very high in carbohydrates, and very inflammatory. Triglycerides. Triglycerides are very sensitive to the quality of the diet, and they can often spike very quickly after a fatty meal or a heavy meal. And this patient, it is elevated. So that tells us about the quality of his most recent exposure and also long-term what his exposure has been. Slightly elevated fasting glucose and the hemoglobin A1C. This is often used in the context of diabetes to diagnose diabetes, but it tells us a lot as well with young patients who are not diabetic. In particular, the hemoglobin A1C is basically looking at glycosylation or glucose that has chemically bonded to red blood cells. And because red blood cells have a length of life of about 90 days, it gives us a picture of exposure to sugar over those 90 days. So when we have both a fasting glucose, which tells us right now what this patient's glucose is at fasting, and we have an A1C that shows 90 days of exposure to glucose, what we see is, wow, this is a patient that is consistently exposed to high levels of glucose, that is low quality diet, that is processed foods and sugar sneaking in things that parents might not know sugars have. Vitamin and mineral blood tests would be an appropriate test at this time. For this patient, it may have been an appropriate thing to look at. It really depends on what your clinical goals are and what your limitations are. But I think looking at those would have been a good idea. Vitamin and mineral blood tests, 100%. And the ALT shows it mildly elevated and possible hepatic steatosis, which is, of course, a sequelae or a consequence of long-term elevations in cholesterol, triglycerides, and fasting glucose. This causes a inflammation of the liver, which over time and even in young patients can cause a breakdown of the liver parenchyma or the liver structure. So it basically doesn't work as well as it should. And the good thing is the liver is incredibly good at recovering. And if we intervene with a patient like this, we can fix all of these issues, all of them. So this is, of course, very concerning, but also shows us that, wow, this is an opportunity to make a difference. And that's how I would say for all of you, when you're looking at these things, look at it like that. Don't say, oh, wow, these are scary results. Say, wow, this is an opportunity for change. And this is an opportunity for change. Next slide, please. What do these labs tell us? Throw it in the chat, folks. You're looking at these labs. I just went through them. What are your concerns? What do you see? What do you know about Jason that you didn't know before we looked at that? How does this complete the picture in your mind of what this patient's exposure is and what our opportunities are today? The labs, what do we see? And I will say generally, high fat and sugar diet, 100%. 100%. And we're seeing the high fat and sugar in different places, and we're seeing it redundantly too. So, yes, pre-diabetic 100%. So one, we're seeing total cholesterol high, LDL high, and HDL low. That tells us that he's getting a lot of fatty foods, a lot of cholesterol in his diet. Triglycerides high as well. It shows that as again two redundant pathways showing us the same thing. Both fasting glucose and hemoglobin 1C, A1C. That redundant pathways, it's telling us that these aren't just surprise results that are coming because a patient, I don't know, went out for dinner the night before. These are the results of consistent exposure, and when compared to a physical exam that shows clear indications of obesity, concerning, but also an opportunity. And families' access to healthy foods is a primary issue. Does this patient live in a food desert? Does this parent have the ability to cook, or does the parent have the knowledge of how to cook healthy foods? These are all things that should be at the forefront of Unite and a family history of chronic disease in particular. Yes. Yes, Donna, 100%. These are things that we can bring into the conversation to help encourage people to make those healthy choices. Next slide, please. So this is just like a breakdown of really what the next steps would be. I won't go too much into it. It's more for your reference. And please take these slides, use them for the elevated fasting and fasting glucose, excuse me. And we'd want to look at a oral glucose tolerance test to measure insulin resistance. We would want to get a full fasting lipid panel. We may want to, and it would depend on the physical exam. Including the abdominal exam, possibly a hepatic ultrasound or LFTs. We would want to check his thyroid as well, see if there's any indication of thyroid disease. We would want to repeatedly check this A1C as we're seeing the patient in the primary care context, because we want to be able to track results and track success. A1C is a great way to do that. Again, it's 90 days of exposure, and you can't hide that. So it makes it very easy to get a picture when you're seeing a bunch of these and to celebrate success. And CBC and electrolytes as well. Someone asked about mineral tests and vitamins, 100%. These are things we would want to check out, and that tells us both about the quality as well. If this patient is potassium deficient, iron deficient, not separately mentioned, but an iron panel as well would be appropriate. Yes. Next slide, please. I agree. The non-medical needs testing is something that should be done at the beginning of every exam. It's a quick way to be able to get that social collateral. And in particular, if you're looking at things like food or housing insecurity, these are primary drivers of obesity, of chronic stress, which is a driver of obesity through chronic raising of cortisol. So that remodels how the brain stores fat and makes that visceral and subcutaneous fat very stubborn. So chronic stress is a primary driver, and your inclination to focus on that is 100% correct, appropriate, and may solve the problem here. Rarely, with something as multifactorial as obesity, are we going to fix it with one issue. It's not just an issue of cutting calories. It is a holistic and multifactorial issue, in that non-medical needs, looking at those social needs, looking at the access to housing, food, so forth, and referring a patient to, if appropriate, a community health worker is one of the best ways you can set them up for success, and you can overall lower the costs of care for this patient. And a vitamin D level, actually, that should be checked. That should have been on the list. Yes. Okay. We're getting into, I think we have a lot of community health workers here. They're starting to think about having the conversation with the patient's family and with the patient. So you are 100% in the right direction. And okay, let's go on to this. So he's presented as alert and cooperative adolescent who appeared older than his stated age. Often obesity can do that for younger kids. It just makes them look bigger, and people treat them like adults, which can be confusing to the children. He's a nice kid. He engaged appropriately during the visit, but demonstrated mild embarrassment when discussing weight and diet. Experiencing obesity as a young child can precipitate behavioral health issues later in life and can precipitate issues with confidence. And that's not just an issue of looking in the mirror, or how society is treating someone, but is an issue. It's an issue oftentimes of exercise as well. Exercise makes you feel great, makes you feel good. Your body's designed to do it. And if you're dealing with high levels of, if you're dealing with obesity, it is difficult to do that comfortably. We see blood pressure 128/78, elevated for the age, heart rate 84, respiratory 18. Next slide, please. Mom is here. Mom is sitting here as well. So, does anyone know what this is? So we're doing a physical exam, and we see it's a two word term. First one starts with the letter A. Second one starts with the letter N. Velvety-like area of darkened pigment. Oh, it says it on the page. Silly me. Acanthosis nigricans, and it is a sign of insulin insensitivity and persistently high glucose. It causes the skin to thicken in key and predictable areas, including the underarms. Next slide, please. On the side of the neck. Next slide, please. And on the back of the neck as well. There was no picture for that. But that is a core finding that's indicative of insulin insensitivity, and persistently high glucose. When I see all of this, I see the results, and I see that it is very clear what we're looking at, and it's very clear that we have dietary issues, nutritional issues, exercise issues, and we have a willingness and interest in change, which gives us our opportunity to make that positive impact. Jason exhibited a rounded facial contour and prominent truncal adiposity. His shoulders, upper arms, and thighs show relatively less subcutaneous fat. This accumulation is typical of the insulin resistance. And we mentioned the acanthosis nigricans. Next slide, please. So we have respiratory, fine, clear. We have a protuberant abdomen, bowel sounds non-reactive, normal, essentially for this patient, normal, other than the size of the abdomen. It's difficult to do abdomen exams on on these types of patients because of just the size of the visceral and subcutaneous fat pockets. Gait is stable and coordinated. Next slide, please. There is bilateral genu valgum in this patient. Typically, this is in younger patients. You can see it a little bit in the older ones. These are exaggerated cases. But there is because of nutritional deficiency in the weight, there is a bending out of the legs, and you can often see this when they are standing. You should be checking it. Next slide, please. So we're going to go through an interdisciplinary discussion here, and I'll ask the team to please tell me when my time is running up. So we're going to have an interdisciplinary discussion. In the next slides, I have a detailed conversation that I won't be able to go through, but I provided for your reference of what the RD would do, what the RN would do, what the MD would do, what the CHW would do. But I'm going to ask Esley to jump on and be my CHW for a moment. And if Dr. Leon is available to be my attending physician, I'd love to ask your opinion on this patient. And I'll start with first, Dr. Leon, did I miss anything? And then I'll go to you, Esley, and say, what do you think we've got to do here to manage this patient socially? Dr. Leon, how'd I do? Did we miss anything here?
Thank you, Dr. Lombardi, for the opportunity. It's really interesting, the case, and as we know, is a priority for this administration. So this is a topic that is really is relevant. and it is necessary to go over this condition, and specifically having a conversation about obesity in our children. But there's something that I would like to highlight based on what you're saying, and is the need to work with uh, the psychologist or the psychiatrist, and provide some behavioral intervention as well. In addition to the BMI, the obesity, and the metabolic issues or concerns, it's always important to make sure that we address the behavioral part of our patients. Is a patient depressed? Is a patient anxious? And provide the feedback and recommendation from a professional about what the patients can do or what the family can do.
So perhaps adding a referral to behavioral health or a screener for depression or anxiety may be appropriate in this case. Esley, this patient is likely to be referred to you and to need long-term coaching. I was wondering if at this point you had any insight as to how we should structure his care.
Yeah, I think I agree with a lot of our comments in the chat that possibly coming from CHWs, I think as a community health worker, the first thing that comes to mind is what's beyond what I'm seeing, right? What's happening at home. And I think it was highlighted all those screeners that reflect the health related needs. We always go back to, are there any health related needs affecting his behavior, his overall wellness? And I think that being connected since the beginning when we're doing these screeners, it's important because CHWs, we know that are uniquely equipped because they know the community, they know the resources, they can connect to the patients, perhaps even if we talk about the language they speak, right? How to lower the literacy of what the doctor is telling them and explaining more thorough. I think CHWs will have a big role. And the post coaching, and I saw a comment as well here where it's not only Jason, but we also have to do some parent coaching and perhaps looking at support groups in the community. Are there any other youth that are going through the same? Because it's not the same when an adult is telling a youth, you need to eat healthier, you need to exercise, you need to do all these measures, but seeing their peers, doing this and improving their health, or perhaps putting examples of youth that have gone through this and excelled and better their health is important. So definitely as a CHW, there's a lot of room. And I think it's a key staff member from your health center that will ensure that everything, all these medical processes are applied, but also ensure in the long term that Jason will enjoy a good health and overall wellness.
And Karen, I see your comment about fiber, and I just wanted to agree that part of the dietary counseling, making sure this patient is eating high fiber food and exercise for relaxation and fitness would allow both weight loss and improved diet and lowered weight in the long run, and that should 100% be a part of his counseling. Esley, long term, that's the support that we're going to need for this patient because he's heading out the door now, and I've got to go to the next thing. And I just grabbed Dr. Leon in the hallway. So this is a patient that is going to need long-term counseling. And I'd say, as far as if when we have the patient and we have the family, what do you think the priorities are for that conversation?
Yeah, definitely is learning what are the gaps. A lot of CHWs, we meet people where they're at. So maybe a home visit will be appropriate if they're comfortable, learn some of their limitations. Once you build trust, they might be able to share, I really receive these food vouchers, but I don't know what to do, or I don't know how to go shopping and buy groceries that are healthy for my family. Perhaps it's connecting them or sharing some recipes that are attractive. Also, they're healthy and attractive for the youth. Is definitely one of the big things of a CHW is keeping in touch and doing routine checks on them, and setting up goals, of course, goals that are going to be connected with your healthcare team, but encouraging and making it also in a way that is attractive to youth people and to you young persons, because maybe there's a strategy, maybe there are games online that they can play and learn about food. But definitely a big, just to round it up, is long term, whereas CHW is really following up, and they know that you're there to support and that you know that you care, and then you're working together with the health team to support their journey.
100%, 100%. So that is the journey we will be putting this patient on. You will be seeing him on a bi-monthly basis for the next 6 months. And this is an insured patient, of course. I will take a step back and say, we live in an era of healthcare triage. We've always lived in an era of healthcare triage. Our resources are limited, and so is our time. Patients like Jason's are priorities. And it's because of just how much of a difference we can make. And that is a priority for both hitting making sure the patient is healthy long term, but also making sure the health center gets the data it needs. And by data, I mean the screening's getting done, the cost of care is going down, the value-based care necessities are being met. That both meets the needs of the patient and the needs of the health center, and shows that people like Esley and like many of the folks on the call here pay for themselves in the long run. So I'll thank Dr. Leon for your oversight, Esley for your intervention, and I will pass it off to Dr. Leon. Thank you.
Thank you, Dr. Lombardi. Next slide, please. All right, we are going to move on, and we are going to discuss another priority that is extremely important for the administration, and sometimes an issue that at the community level is affecting our populations and is more frequent. As Dr. Lombardi said, my name is Dr. Jose Leon, and I serve as the Chief Medical Officer for the National Center for Health and Public Housing. And I also serve as the Chief Population Health Officer at La Maestra Community Health Center. And this time, on the rest of the presentation, we are going to talk about exposure to chemicals, which is another important issue. And again, is part of the administration's priority. And there are several ways that our children and our patients are being affected by chemicals. We know about heavy metals, for instance, in public housing. The main concern is exposure to lead. And remember that lead can be found in paints and pipes or dust. So it's always, always important to link any symptom with our patients with the environment or the environment where they live in, and specifically in the community. We also have exposure through air pollutants. Carbon monoxide is a big concern, as well as nitrogen dioxide. So it's always important to have a conversation about all these possible ways or possible pollutants and how patients can be affected by this type of chemicals. We also know that we have pesticides in the environment, as well as some physical agents. Microplastics is a big concern in our communities and in different countries, as well as organic pollutants like dioxins and waterborne contaminants as well. Is always important to make sure that we understand where our patients live, what they do, the type of water that they are drinking, etc. Next slide, please. It's very important for health centers to understand how our children can be affected. Remember that even if they are not affected directly, it can be they could be affected when they're in utero or even during preconception. So it's always important that in addition to getting information about the patient, we need to get information about the parents. And in the it's important this issue because sometimes we believe or we think that health centers cannot have a role, and in reality, we do have a role. The Tijuana River watershed, for this is an area that is between Baja California and San Diego. And this region has been affected by pollutants that are in the water. And we have different issues like industrial waste. We have runoff and contaminated runoff. And the concern here is not only the pollutants, but even infectious diseases. We have issues like hepatitis A that we need to consider and how the patient was exposed to the virus. All these all this background information is necessary when we are doing all this history, as Dr. Lombardi mentioned, how important it is to get information from parents or from relatives is the same when we do history on chemical exposure. So, what's the role of the health centers? In regards to this issue, in San Diego, California, we had in that area around 55,000 patients. And we had a conversation with our team regarding how we can help our patients, what we can do to assess the needs of our patients. So what we did was that we had a conversation, we analyzed our electronic health records, we assessed the needs, and we found that around 5,000 or over 5,000 of these patients are patients with some respiratory conditions. We're talking about asthma, we're talking about chronic diseases, lung diseases, and we said, okay, how we can help this patient, how as a health center we can provide some type of relief to the patients, in addition to the education, in addition to provide them with information about the dangers and the issues concerning this crisis. We have a conversation on how we can help these patients. And one of the ideas that we had was, okay, let's provide with some air purifiers to our patients. If they are not being directly affected, and if we have an exacerbation of asthma and other respiratory conditions, what we can do is to make sure that at least when they are in their household, they are having a better or better conditions. So we worked with Americans. We went to Americans and explained to them the issue, the concerns, and we were able to secure funding and provide air purifiers to these patients. So we are in the process of identifying patients, educating patients. We are working with our CHWs, making sure that they understand how these air purifiers work, and they will be the ones providing instructions to the patients. And the role of the clinical team will just to make sure that there are not exacerbations that are related to the exposure of these pollutants in this area. Next slide, please. Why is so important to talk about environmental hazards and take the information that we need from our patients? It is always important to know about location. If we are having a patient if we think that this patient has or the symptoms are related to exposure to a chemical, it's always important to talk about location. And what I mean is, do symptoms get worse or subside in some particular location? Sometimes is the patient better at home? If the patient not so good in the school or a daycare, or if this patient go to the playground, or if it's in the community. So it's always to make sure that we identify the location and whether or not the symptoms get better or get worse. Then we need to establish a temporal relationship. It's important to know the period of time. When is the patient having these issues? Where is this issue related to a visit to the grandparents, for instance? They go over the grandparents' place and have a conversation and have a meal, and then when they get back home, they're having some symptoms or some exacerbation of the symptoms. Also, the activity is very important. It's important to know whether or not there is an activity that is either improving or worsening the symptoms of the patients, and whether or not others are affected. Is not only our patient, but if we are in the community and we hear that are other cases or an outbreak in the community, that is giving us the information that we need to link the symptoms of our patient with any environmental hazard or any chemical exposure. Next slide, please. So once we have all that information, we have to ask ourselves, is the child's specific health condition related to any environmental concern that we have or any chemical exposure? Have we gathered that information from our patients or from the parents? Is the exposure the cause of the symptoms? That's another big question that we need to ask ourselves, and making sure that we gather the history and all the information that we need from our patients. Because even if a patient is exposed to a chemical, it doesn't mean that any or the symptoms that at this moment the patient is having are related to any chemical exposure. Also, a question is there any scientific evidence linking the health condition to a particular substance? If we have a patient and we have a patient who is having some behavioral issues, for instance, an anemia, are these behavioral issues and the anemia related to any exposure in the environment that we believe is the cause of the symptoms or the disease that the patient is, well, for the or the condition that the patient is experiencing? And the other thing that is also really important is to identify signs and symptoms and whether or not they are related to the conditions that the patient is experiencing. So all these questions are very important, and we need to make sure that we gather that information so we can say that if there is a disease that is due to any of this chemical exposure, we need to find the evidence linking both the symptoms and the type of substance that the patient is being exposed to. Next slide, please. So what is next? Remember that if there is an exposure to any chemical, we need to try to find some biomarkers if they exist, making sure that the patient is referred to the appropriate lab, making sure that the blood work or the exams that we are asking are related to the condition that we think is going to be the cause. And we also need to check the home environment. And Ashley had a brief conversation about home visits. If this is something that we believe is related to an exposure in the household, that this is a really good opportunity to go and visit our patients. Next slide, please. So it's always important to work with our community partners and making sure that we understand what is happening in the community. In the case that I mentioned in the Tijuana River watershed, the state and the local health departments have been involved, and all the information is being shared with our patients, making sure that they understand the crisis, making sure that they understand the type of exposure that they can have, making sure that they understand the issue well. Leslie also mentioned health literacy, which is really important to provide information that patients can understand and making sure that they can make the changes and have this particular conversation with our patient, making sure that they understand the issues and how they can prevent this issue. Next slide, please. We have something that can be added to the electronic health records in case somebody is interested. WHO, the World Health Organization, has what they call the green page. And this is a really good resource just to make sure that we take chemical exposures history and it can be really easily added to the electronic health records, or just to have it in the clinic and making sure that we follow the recommendations that the World Health Organization is providing to providers or to clinicians, not only in the United States but around the world. Next slide, please. We also need to make sure that we address the public services, the type of water, in the house, school, and community, and then add some comments and recommendations. Next slide, please. These are all the resources, the checklist. This is something that the U.S. Department of Housing and Urban Development has developed for housing leaders, but at the same time, it can be also used by CHWs, making sure that there is a checklist that they have access to if they are going to our patients' places, and making sure that we analyze and assess any chemical exposure. Next slide, please. Same with the toolkit. This is another document from the U.S. Department of Housing and Urban Development, and this is for housing counselors. That's the link where you can access this toolkit. Next slide, please. And EPA has also some indoor air quality guide. These are some fact sheets and resources that we can provide to our patients. We have 5 more minutes, so I'm going to stop here and see whether we have any questions that we need to answer